We're going to talk about fluids and electrolytes. The body is made up of approximately 60% fluid, and most of this fluid is located in the skeletal muscles. You have intracellular fluid and extracellular fluid. The intracellular fluid is located in the skeletal muscle mass. Your extracellular fluid is in the intravascular system. Interstitial fluid is the lymphatic system, so your lymph nodes. Transcellular fluid is fluid that is found in the cerebrospinal column, so your spinal cord and your brain, the fluid that protects those structures. And then pericardial fluid is a very small amount of fluid that is in between your heart muscle and the pericardial sac that protects the heart. Synovial fluid is what is found in your joints that helps lubricate the joints so that we can move. This is pictures that show where fluid is located, so you can see the intravascular space, that is your blood vessels. Interstitial space is the space in between, and then your cells. So we'll have fluid located in these different spaces. 5% of our fluid is plasma, 15% is interstitial, and then 40% of your body weight is intracellular fluid that's in the skeletal muscles. So our body lives in a natural state of equilibrium. Our body manages this equilibrium by itself. We don't have to do anything under normal circumstances for our body to maintain its fluid balance. Electrolytes and fluids are really within narrow limits, so our body cannot tolerate our electrolytes going outside of their normal limits too much, and we must intervene and correct those imbalances if our body is unable to do so. First, we're going to talk about hypovolemia. So this is when our body does not have enough fluid. There's many reasons that can cause hypovolemia. Signs and symptoms of hypovolemia can be high blood pressure, weight loss. So as we said earlier, our body is about 40% of our weight is fluid. So if we have a drastic weight loss, that can be all water causing hypovolemia. You're going to see tented, dry skin. So when you're assessing skin turgor, this is where that when you pinch their skin, it would stay tented. They'll have an increased respiratory rate and an increased pulse rate, so they'll be tachycardic. They'll have cool skin, flat neck veins. So when you look at their the veins in their neck, they won't be distended at all. They won't be the normal volume that they look. They'll be nice and flat. Oliguria, this is the absence of urine, so they are not currently making urine. Lethargy is another sign. When we go to assess these patients, first we need to start with their history. As with any patient that we are assessing, we need to know what's going on, what led up to this event. So we want to get their nutritional status. Are they eating the way they should? Are they drinking the way they should? Have they had recent body weight changes? Do they have any kidney or endocrine disorders? So, or even a history of such? Do they have a family history of kidney disease? Do they have an endocrine disorder such as diabetes insipidus or any diabetic issue? What kind of fluids are they drinking? So if they drink soda all day long, that's not really good for them. Soda has caffeine in it, which is a natural diuretic. Are they eating an adequate diet? Are they eating enough regular healthy food? What's their urine output? Are they on a diuretic? Are they on too much of a diuretic? Have they been outside all day and they've been in the heat and they're sweating? So they've lost more water through perspiration than they think they have, and all of a sudden they're dehydrated. Have they been sick for a few days and they have diarrhea? Are they using laxatives for whatever reason? Excessive use of laxatives will obviously cause diarrhea, and we lose a lot of water through diarrhea. And then a lot of people don't think about how much fluid loss they have if they are running a fever for extended periods of time. So your body's natural mechanism for managing fevers is to sweat, and you'll lose water that way as well. So we're going to assess their skin turgor and look at their mucous membranes. Mucous membranes can tell you a lot about a patient's hydration status. Are they cotton mouth? Do they complain of just an excessively dry mouth? Then that would indicate they're not drinking enough. Their eyes, are they able to cry? Are they able to make tears? Are they acting appropriately? What's their neurological status? Are they confused? Are they anxious? Are they able to walk straight? Are they dizzy when they stand up? So taking all these things into account when we're doing our physical assessment. When we do a neuromuscular assessment, that goes with walking. Are they weak when they stand up? Are they able to take a few steps? Are they able to even, lift their arms off the bed? They could be so weak that they can't even move. Psychosocial factors can play into hydration and nutrition status as well. Depression, a lot of people who are depressed don't feel like eating or drinking, or they can be depressed and be drinking excessive amounts of alcohol. Eating disorders such as bulimia and anorexia can also lead to hypovolemia because they're just not taking in adequate amounts of fluid or nutrition. And then social practices such as alcohol use or drug use. Excessive use of either of these can lead to some bad outcomes. So what would we want to monitor on a patient who's hypovolemic? We want baseline vitals, and we're going to check these vitals frequently as we are doing our fluid resuscitations. We want to watch their intake and output, so we need to know how much fluid is going in and how much fluid is coming out. These people will be on a strict intake and output measurement, so we need to have an accurate way to measure their urine output. So either if they're too weak to get up and walk, we may consider a Foley catheter. If they are able to stand and at least go on either a bedside commode or maybe walk into a bathroom, then we can use a hat, or males can stand at the bedside and use a urinal. We want to get baseline lab values. We need to know where they stand. If they're hypovolemic, their H&H could be concentrated. Do they have edema or an absence of? So if they are hypervolemic, so they have too much fluid, they might be edematous. But if they're hypovolemic, then they're not going to have any edema. These patients are going to get daily weights, and the important factor with daily weights is that we are weighing them the same method at the same time during the day. So typically these would be done early morning, but as long as it's done at the same time each day, that way we get accurate picture of their weights from day to day. Orthostatic blood pressures, so we've discussed these before. These can be indicative of a patient at risk for a syncopal episode. So when we go to measure orthostatic blood pressures, remember that we first measure the patient's blood pressure with them laying flat, and then we'll sit them up in the bed or in the chair and measure their blood pressure sitting up, and then we'll measure their blood pressure standing. And we're looking for more than a 10-point drop in their blood pressure, in the systolic blood pressure, or a more than 10 to 15 beat increase in their heart rate. This would lead us to believe that they would be a high risk for a fall related to a syncopal episode. We're going to we're going to assess their neurologic status. So we want a baseline neuro assessment. Do they know who they are, where they are, what's going on? If a patient can tell you the day of the week, but not necessarily the date, so for instance, they can tell you that it's October 10th, but they can't tell you the year. If the date is correct, I give them credit for knowing time. If they can tell you that it's morning and it is clearly morning, I give the patient credit for it being the correct time. If they tell you it's December and it's the middle of summer, then they are confused to time. We're going to assess their respiratory status. So hypovolemic patients can be a little tachypnic, meaning their respiratory rate will be fast or faster, so higher than 20 respirations per minute. And then we're going to assess their cardiac status and peripheral pulses. Very important that we assess all 4 peripheral pulses, and then comparing each side. So they could be there could be discrepancies between the left and right side for peripheral pulses. This picture references blood samples in relation to hydration status. So you see the blood vial on the left. This is hemodilution. So all this up here is fluid, and this down here is our blood cells. So their hemoglobin and hematocrit will be lower. A normal hemoglobin and hematocrit, so as you see the fluid up top once they spin it down, and then the blood cells on the bottom. And then hemoconcentrated, so we've got just a little bit amount of fluid, and then all these blood cells. So this indicates dehydration. So overhydrated right here, dehydrated right here. This is where we want to live. So what do we need to do for our patient? If they are hypovolemic, they need fluids, and they need a lot of fluids. We can't give them too much at one time, so we don't want to give them 2-3 liters of fluid, because then we could send them into some breathing problems because they have more fluid than what their lungs can handle. But a nice steady rate, probably 125 an hour maintenance fluids after they've gotten at least a 1 liter bolus would be acceptable. We're going to check their lab values when they first come in, and then they'll probably get maybe an additional lab values drawn later on in your shift, or the physician might want to wait until the following morning. And that's all going to depend on the acuity of your patient. The sicker the patients, the more frequent their labs will get drawn. If they're stable, they can wait 12 to 24 hours between lab draws. We'll be monitoring strict I's and O's. We need to consider if they are a fall risk, and do they need ambulation restrictions? Do they need the fall pad next to the bed, or do they need the pad that's in the bed that if they move off, it will alarm? Or are they able to get up and walk to the bathroom independently or with a standby assist? We really want to push oral fluids in these patients. We will obviously be giving them IV fluids, but it's very important that these patients take the initiative and drink as much oral fluids as they can. Again, the bed alarm, depending on their neurologic status, if they can understand their restrictions, then they wouldn't need a bed alarm. But if they're non-compliant or so confused that they don't understand the reason they can't get out of bed, then you need to put a bed alarm on these patients. So we'll be able to tell if these patients are getting better by their urine output. So obviously that the urine output will increase. Their vital signs will get better. Their heart rate will slow down. Their respiratory rate will slow down. Their mucous membranes will start looking moist. They'll become less confused if they were confused initially. But mostly their vitals and urine output are going to be the true signs of improvement. So fluid volume deficit, so this goes along with hypovolemia. So this is your nursing diagnosis. So we're monitoring for factors that caused the deficiency in the first place. Were they sick and not able to drink? Did they just not want to drink? Was there depression? We're looking for signs of hypovolemia. Are they restless? Are they weak? Do they have muscle cramping? Intake and output and daily weights, and then vital signs and orthostatic blood pressures. Fluid volume deficit versus fluid volume excess. So in fluid volume excess, we have that retention of water. So these are your congestive heart failure patients, your patients who just have drank too much water, so they're overhydrated. Same assessment findings as, or same assessment parts as deficit. We want to know what their level of consciousness is, their neurostatus. We're listening to heart and lung sounds. With fluid volume excess, you would expect those lung sounds to be wet or crackly, because you'll hear that fluid in their lungs. Intake and output. So if they have that excess, that fluid volume excess, their intake is going to be greater than their output. So we need to take a look at what's causing that. Are their kidneys just not functioning properly and not making as much urine as it should? These patients are going to need strict fluid restriction and sodium restriction, because sodium causes our body to hang on to fluid more than it should. Deficit, we have that loss of solutes and water that causes the hypovolemia. These patients have poor oral intake, and you'll notice in assessment that skin turgor, the tenting of their skin, their mucous membranes are going to be dry, they'll complain of thirst, and their urine-specific gravity will be concentrated. We want to provide fluids to these patients and educate them on the appropriate hydration. So here's more on hypervolemia, or fluid volume excess. So this is the abnormal retention of water and sodium in equal proportion. So the body's just holding on to everything. And this, the fluid's found in the extracellular fluid. So our homeostatic mechanisms are diminished. You'll have these patients will be heart failure patients, kidney injury, or liver cirrhosis. So your kidney patients don't make urine, so the fluid backs up into their extracellular space. Congestive heart failure, our heart isn't pumping correctly, so we have that fluid back up in systemic circulation. These patients, again, restrictive dietary salt intake, and then we really want to monitor how much IV fluids we're giving them. We have to document everything that goes in these patients, because everything that goes in has to come out one way or the other. The fluids increase because our sodium levels are going to increase as well. We're going to see confusion, weakness, muscle twitching, hyperreflexia, and even coma if the levels get too high. We already covered this a little bit. Kidney failure, congestive heart failure are your two biggest fluid retention. Too much IV fluid, so if you give a patient 2, 3, 4 liters of IV fluid because they have a low blood pressure and you're trying to fix that, you could potentially send them into a hypervolemic state and their body's not able to get rid of that fluid effectively. If we have a patient who is just eating an extremely high salt diet, water follows salt, so all that fluid stays in our system. And then liver failure patients, that's the ascites, the big-bellied patients that need the paracentesis. They'll have 3, 4, 5, 6, even 7 liters of fluid just in their abdomen, and will require procedure called paracentesis to drain that out. Symptoms for these patients, obviously weight gain. You'll hear crackles in their lungs. they'll be short of breath because of the fluid in their lungs. So short of breath, or dyspnea is another word. And swelling in their extremities is where we're assessing for that pitting edema. So 1, 2, 3, even 4 plus pitting edema, and signs of congestive heart failure. So here's our nursing management for fluid volume excess. So again, this is too much fluid going in the body and our body not able to effectively eliminate that fluid. So I like pictures because I learn better with visual. So hopefully this picture kind of helps you guys understand the concepts. So they'll have an increased blood pressure because there's increased pressure in their vascular system from the fluid. JVD, so that's the jugular venous distension, so their neck veins will be puffy, sticking out. Tachycardia, they're not going to feel like eating. They might be nauseous from the fluid overload. They'll have the dependent pitting edema, so their feet will be quite swollen, feet and bilateral lower extremities. Changes in their level of consciousness. They might be confused, complaining of a headache. Headaches go along with the increased blood pressure. And if it gets too bad, they could even have seizures. For their respiratory system, that pulmonary congestion or the crackles in their lungs when you listen to their lung sounds. Daily weights, very, very important. We need to know what they weigh at the same time every day and if our treatments are effective in eliminating fluid. Strict adherence to fluid intake. These patients are not going to be happy. They'll be restricted to maybe 1 liter of fluid a day that they could drink, and they will go through that very quickly. We need to educate them on diet modifications to avoid excess sodium intake. They need to rest because they are not going to be able to tolerate activity very well. And then education. Every time we can educate these patients on diet and rest and any of the interventions that we're doing and why we're doing them. Here's a picture that kind of shows the different levels of edema. So +1 is just barely detectable. +2, you'll have about 4 millimeters of indentation. +3 is about 6 millimeters. And then +4 is that more than 7 millimeter indentation. Hypovolemia versus hypervolemia. Just going over this one more time. The fluid volume deficit is when we have a loss in the extracellular fluid, or there's an unequal ratio of intake versus output. Vomiting, diarrhea, sweating, even suctioning. So we've gone over suctioning a little bit now. Patients who have an NG tube, if they are on continuous suction or a higher level of intermediate suctioning, you could accidentally take out too much fluid, and that can cause hypovolemia. Burns and ascites are big types of fluid loss that cause third spacing. So this is when too much fluid moves from the intravascular space to the interstitial space, so that space between the vasculature and the cells. So it's not in our blood vessels and it's not in the cells, it's floating in between. Diabetes insipidus, so this is not diabetes mellitus. This occurs when there's too much fluid and the kidneys are not able to concentrate the urine normally. So these patients are going to urinate excessively, but it will be very diluted urine. Your antidiuretic hormone, which you guys will learn more about in our endocrine lecture later on this semester, is what regulates this. So electrolytes are lost in the same proportion to water loss, and this leads to our elevated serum sodium. So what are these electrolytes that I'm talking about? So electrolytes are in the body. Sodium, potassium, calcium, magnesium, and hydrogen are our cations, so they carry a positive charge. Your anions, which carry a negative charge, are chloride, bicarbonate, and phosphate. We need these to regulate nerve stimulation, muscle function, and our hydration status, and they balance blood acidity. So your bicarbonate is a big, sodium bicarb is a big medication that we'll use in critical patients if their blood is too acidic. Here's our ranges, so you guys need to memorize these ranges because these will come up in test questions. You'll need to know, the differences between a high or low value of each of these and what those can manifest as symptoms in your patient. Sodium is hypo or hypernatremia. So our regular levels are 135 to 145 mil equivalents. Potassium or hypokalemia and hyperkalemia. So that's 3.5 to 4.5. So hypokalemia would be below 3.5. Hyperkalemia would be above 4.5. Hypocalcemia, hypercalcemia, 8.6 to 10.2 milligrams per deciliter. Magnesium is hypomagnesemia or hypermagnesemia. So that's 1.5 to 2.5. Phosphorus, hypophosphatemia and hyperphosphatemia, 2.5 to 4.5. And chloride, which is hypochloremia or hyperchloremia, and that is 96 to 106 milliequivalents. So what is the difference between hypo and hypernatremia? So hypo is a serum sodium less than 130. This is usually caused by a brain injury that causes an overexpression of the antidiuretic hormone. Diuretics can cause this, so we would be monitoring sodium levels in patients on a diuretic. Rapid fluid loss, so these are patients if they're on a laxative or they're significantly restricting their diet. We treat these patients by treating the underlying cause. So if it's too much diuretics, we stop the diuretics. We replace fluids. Regular sodium chloride will replace these. Replace their sodium. So you'll see some patients on sodium tablets, and restrict water intake. So if they're just drinking excessive amounts of regular tap water or bottled water, that doesn't have sodium in it. So they can get hyponatremic because they're, well, I'm drinking water. It doesn't make sense. Why am I hyponatremic? Well, you're not drinking anything that has salt in it. Hypernatremia is when your serum sodium is greater than 150. So these patients are going to have a normal fluid volume. So their vital signs will be normal. Their neurologic status may be normal, but they could be cognitively impaired because they're going to have excessive thirst. They'll have an elevated body temp and dry mucous membrane. So their sodium is high, but they still need they'll need fluid to dilute that. They'll be weak, and they could go into seizures. Hypokalemia and hyperkalemia, so this is our potassium levels. This is probably the most common electrolyte imbalance that we're going to see in the hospital setting. We replace potassium frequently, and your replacement protocols will be based off of your facility's protocols. So hypokalemia is a serum potassium less than 3.5. This can be caused by vomiting or diarrhea or prolonged GI suctioning. So they have an NG tube and we're suctioning too much from that tube, or poor dietary intake. You'll see EKG changes, and we'll cover EKG more next week. Dysrhythmias, so that's an abnormal heart rhythm. They'll have diluted urine and muscle weakness. So our muscles rely on sodium and potassium to function appropriately. So if we have hypokalemia, then our muscles will be weaker than normal. We need to replace their potassium, obviously, and in doing this, we monitor for EKG changes, because if we get too high with potassium, it can cause those arrhythmias. Monitor their ABG status. So some hospitals will, some hospitals will not. It depends on the acuity of your patient. So by ABG, I mean arterial blood gas status. And then digitalis toxicity can also cause hypokalemia. So patients who are on digitalis, we need to monitor. Hyperkalemia. So this is seen in patients with abnormal renal function. If our potassium level gets too high, it can lead to a cardiac arrest. You'll see some renal function patients, impaired renal function patients, who will have a potassium level upwards of 6 or 7. These are critical levels. They need to be managed immediately, because these patients can go into cardiac arrest. Calcium gluconate is a medication that these patients will get to temporarily counteract hyperkalemia. And then sodium bicarb would also be given to these patients to counteract the acidosis and move the potassium back into the cells. So keep in mind, when we have these values, that means that there's too much potassium in the extracellular space. So that's why we have the elevated levels. So we need to get the potassium back in the cells. They will also give insulin to facilitate the uptake of glucose back into the cells, because potassium will follow glucose. So all of these medications combined will lower the potassium level. You'll also give these patients IV dextrose, because if you give a patient who is not a diabetic insulin, that will drop their blood sugar level and give you a whole new set of problems. So these patients will get dextrose after the insulin to prevent a too low of a blood sugar drop. We're going to monitor these patients for cardiac changes, muscle weakness, and anxiety and GI symptoms. So these patients can get tachycardic, which can make them feel anxious. We monitor their cardiac functions, and we restrict potassium intake. Kayexalate is a medication that you can use in a stable patient. Kayexalate is a medication that will cause diarrhea, and potassium will follow the water loss through the diarrhea. And again, the emergent management is that IV calcium gluconate, sodium bicarb, insulin, and then the dextrose. A lot of these patients, especially renal failure patients, they need dialysis sooner rather than later, because the only way that you're going to get rid of that excess potassium is through dialysis. Hypocalcemia. This is when your serum calcium level is less than 8.6. Calcium and albumin go down together, and for every 1 gram per deciliter drop in albumin, there's a 0.8 drop in calcium. Your parathyroid hormone and calcitonin control these. So your patients with hypoparathyroidism, so their parathyroid glands aren't working appropriately, patients with osteoporosis or pancreatitis can also have hypocalcemia. Massive blood transfusion. So you guys will cross this when you get into your critical care rotations or critical care in Block 4. Blood products have citrate in them. That is a preservative for the blood products. Calcium binds to this citrate and pulls it into the cells and out of the extracellular fluid. So you will have a drop in your serum calcium levels, because that calcium is not where it can be used. So in patients who are getting excessive blood products, they're going to need to also receive calcium replacement. Kidney injuries can cause hypocalcemia, and then some medications. So your signs of hypocalcemia, these are your Trousseau's and Chauvet's sign. So you tap on the patient's cheekbone and that side of their face will spasm. And then the Trousseau sign, you inflate a blood pressure cuff on their arm, and as you see in the picture there, their hand will curl up. These patients need to be on seizure precautions if these signs are positive, because they could seize. We're going to give them oral calcium and vitamin D supplements. So calcium is much better absorbed when it is given with vitamin D. These patients will need physical therapy and then exercise and diet education. If they are emergent management, and so their calcium levels are extremely low, we're going to give them IV calcium gluconate because they are going to need it quicker than oral replacement will fix the low problem. Hypercalcemia, so this is when your serum calcium level is greater than 10.2. It's often you'll see a reciprocal decrease in phosphate. So when one is high, the other's low. When one is low, the other's high. Hypercalcemia, these patients will unfortunately have a higher mortality rate because this is one of the electrolytes that our body does not tolerate outside of its normal levels. Cancer, so malignancy, hyperparathyroidism, bone loss can cause this. So your osteoporosis patients, when the bone is breaking down, causing excessive calcium in the blood. And then diuretics can also cause this. These patients are going to have bone pain, so their joints and major bones are going to be sore, and they're going to complain of pain. You'll see EKG changes, so dysrhythmias. They'll be weak. They'll have excessive urine output, so polyuria, muscle cramps, and even diarrhea or nausea, or they could have severe constipation. So there's kind of a lot of different things that can be going on. And in order to determine that, we just need to monitor their blood levels. These patients might have a lot of kidney stones. So when we have a lot of calcium in our blood, our kidneys can't necessarily filter all of that out, so we'll have some kidney stones form. Managing these patients, they need large amounts of IV fluids to, one, dilute the calcium level, and two, to enhance renal function and excretion of that calcium. So we're going to give them a bunch of fluid, and then we're probably also going to give them a diuretic like furosemide, or Lasix is the other name. Give them that to help their kidneys, basically kick them into high gear to pee a lot. If their renal function is normal, we can try oral replacement of phosphate to try and counteract that. But these patients, again, the cardiac arrest is a big risk for these patients. Hypomagnesemia, so when our serum magnesium level is less than 1.3. You will likely see hypomagnesemia if they are hypokalemic and hypocalcemic. Malnutrition or malabsorption, so these are your failure to thrive patients, cancer patients, patients who just don't have a good health status. Alcoholism can cause this, renal tubular dysfunction, so our kidneys are not working right. Metabolic acidosis, which we'll cover later on in endocrine. Thiazide and loop diuretics can cause hypomagnesemia. Similar to our hypocalcemia clinical manifestations, the EKG changes, Neuromuscular irritability, so muscle spasms, muscle weakness, the Chosovec and Trousseau signs, and then we need to replace their magnesium with IV or PO. A lot of times your physicians might replace with both because the IV will burn through quicker. But the PO is a slower absorption but lasts longer. Hypermagnesemia, so when our serum magnesium level is above 2.5, we will rarely see this. Typically caused by an overdose of antacid. So they have that, bottle of antacid and they're just drinking it because they can't get rid of the heartburn, and then they've got a high magnesium level. They're going to have slower reflexes, cardiac irregularities, and hypotension. When you guys jump to labor and delivery next semester, you'll monitor patients who are on magnesium infusions for neuroprotection with neuroprotection for pregnancy-induced hypertension or preeclampsia. So you'll see this. Hopefully you won't see this in those patients, but this is where we would monitor for it. These patients are going to need strict magnesium intake, dietary changes, and no more antacid use, which they're not going to be happy with, but it's going to hurt them in the long run, so they need to stop using them. Hypophosphatemia is when our serum phosphorus level is below 2.5. Our intestines aren't absorbing the way they should, and then we have our kidneys that have an excessive excretion of phosphate. You'll see a vitamin D deficiency with these patients. Alcohol use or abuse, so excessive alcohol use, refeeding syndromes after starvation. So you have like an anorexic patient that you're trying to refeed, you could see low phosphorus levels, and then respiratory alkalosis. Signs and symptoms are confusion, muscle weakness, tissue hypoxia, and muscle and bone pain. And then your management is IV and PO replacement of phosphorus. So you can see that for the most part, our body does not tolerate levels outside our normal electrolyte levels. A lot of our symptoms are the same. A lot of the same neurologic symptoms, same cardiac symptoms. We're monitoring these patients for EKG changes and respiratory status. Are they confused? Is their confusion getting better? What's their kidney function? What's their urine output? And stuff like that. So this is your lecture for fluid and electrolytes. I wanted to give you guys a review because this information will be on your first test. So thank you.